Hello, my name is Lamont Scales, and I would like to welcome you to the CDC's COVID-19 response, Promising Practice number 2 webinar, which is a part of our series that we hope to continue. Today's webinar will focus on key activities that jurisdictions have taken to reduce COVID-19 disparities among racial and ethnic minorities within the United States. We would like to thank you for joining the webinar today. We would also like to extend a special thank you to the staff at the National Association of County and City Health Officials for helping us to coordinate this webinar. Next slide. Please use our Q&A function to submit questions and our chat box to share comments and resources. Again, please use our Q&A function to submit questions in our chat box for comments and resources. A special thank you to those that have submitted questions in advance. We try to incorporate them into our structured questions, which you will see a little later. This webinar will be recorded and later posted on CDC's Racial and Ethnic Minority Group website. As an FYI, this webinar is not intended for the media. Media can direct their questions to media@cdc.gov. Next slide. I'm very pleased to be joined today by Dr. Leandris Liburd. Dr. Liburd is the Associate Director for the Office of Minority Health and Health Equity at the Centers for Disease Control and Prevention. In this role, she leads a wide range of critical functions in the agency's work in minority health and health equity, women's health, and diversity and inclusion management. She plays a critical leadership role in determining the agency's vision for health equity, ensuring a rigorous, evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in vulnerable communities. Dr. Liburd has been appointed to the CDC's COVID-19 response as the Chief Health Equity Officer to expand the health equity approaches within the COVID-19 response work. Dr. Liburd holds a Bachelor's of Art degree from the University of Michigan at Ann Arbor, a Master's of Public Health in Health Education, Health Behavior from the University of North Carolina at Chapel Hill, a Master's of Art in Cultural Anthropology, and a Doctor of Philosophy degree in Medical Anthropology from Emory University. I'll now turn it over to Dr. Liburd to share a few remarks and moderate today's webinar. Dr. Liburd.
Thank you, Lamont, and greetings and good afternoon, everyone. Thank you all for joining our second Promising Practices in Health webinar. The past 6 months have galvanized the nation to overcome a pandemic that has amplified historical health inequities and challenged us to develop and implement innovative strategies that will address health disparities and achieve health equity. The charge to public health professionals, which is as critical now as it has been in the past. I've been privileged to spend my entire public health career in the struggle to reduce largely preventable health disparities and pursue health equity. In the 9 years I've served as Associate Director for CDC's Office of Minority Health and Health Equity, I've lent my voice and expertise to addressing a range of health issues and to shining a light on those social factors that help construct patterns of health disparities. The population health impact of COVID-19 has exposed in plain sight decades, if not centuries, of inequities that have systematically undermined the physical, social, material, and emotional health of racial and ethnic minority populations and other groups. I thank each of you for the work you do every day to make a difference in the lives of people everywhere, and believe you will leave this webinar with new ideas and some restored hope for how we can accelerate our efforts to achieve health equity. In my role as the first Chief Health Equity Officer for the COVID-19 response, I have been pleased to help chart the path forward for CDC's COVID-19 health equity strategy based on principles to reduce health disparities, to ensure that useful data is available, to meaningfully engage community institutions in planning and implementation of critical work, to implement outreach that is culturally responsive and tailored to address the unique circumstances of groups at high risk of COVID-19, and to reduce stigma, including stigma associated with race and ethnicity. Persistent health disparities combined with housing patterns, work circumstances, and other factors have put members of many racial and ethnic minority populations at highest risk for COVID-19. I am going to just say in closing that this health equity strategy that we recently released is focused on 4 priorities. One is to expand the evidence base to increase our understanding of the impact and the factors that lead to the disproportionate burden of COVID-19, to expand testing, contact tracing, isolation options, and care, reaching populations that have been put at increased risk. We also intend to expand intervention activities to support essential and frontline workers to prevent transmission of COVID-19, and increasing an inclusive workforce equipped to assess and address the unique needs of an increasingly diverse population. I don't want to take any more time away from our amazing speakers, so I'll stop here and emphasize that CDC is aggressively responding to the global outbreak of COVID-19. So I'd like to introduce our first speaker, who is David Saunders, who is the director of the Office of Health Equity at the Pennsylvania Department of Health. In addition to more than 30 years of nonprofit management experience, David brings with him extensive knowledge in the fields of education, public health, disparities, and youth development. He has collaborated on health equity and health disparity reduction initiatives, developed cutting-edge programs targeting underserved communities, and established state training institutes, collaborating with state, county, and local officials. In April 2020, David took on the massive task of developing a collective response to COVID-19 and the implications of the pandemic on vulnerable populations in the Commonwealth. 15 population groups were explored from a variety of angles, using 12 stakeholder groups with an eclectic membership including government, academia, nonprofit, and healthcare. 60 recommendations were developed that seek to mitigate the effects of the pandemic both now and in the future. And we're going to learn some of what David has been doing over the past several months. Our second speaker is Jim Bloyd, Regional Health Officer of the Cook County Department of Public Health. Mr. Bloyd has worked as a disease intervention specialist, contact tracer in the STI program. He has helped establish a school-based health center in Cicero, Illinois, and in 2015, he co-led the community health improvement planning and assessment process that prioritized structural racism as a public health problem for the Cook County Department of Public Health. In Illinois, he spearheaded the Cook County Department of Public Health Roots of Health Inequity Dialogues Staff Development Initiative. Recently, he supervised the COVID-19 phone hotline and was staff for the director's weekly webinars updating suburban Cook County partners on pandemic information. He is on the steering committee of the Collaborative for Health Equity Cook County, a part of the National Collaborative for Health Equity. And our third speaker is Dr. Aletha Maybank, who joined the American Medical Association in April 2019 as their inaugural Chief Health Equity Officer and Vice President. Her role is to embed health equity in all the work of the AMA and to launch a Health Equity Center. Prior to this, in 2014, Dr. Maybank became an Associate Commissioner and later a Deputy Commissioner and launched the Center for Health Equity, a new division in the New York Department of Health and Mental Hygiene geared towards strengthening and amplifying the health department's work in ending health inequities. Under her leadership and in a short amount of time, the City Health Department made great strides in transforming the culture and public health practice by embedding health equity in the health department's work. This work has been recognized and adapted by other city agencies and has even captured the attention of the CDC and the World Health Organization. So now I will give the speaker some time to provide what their overarching message is and how we can address health disparities, starting with David, and then I will return with more questions.
Thank you, Dr.
David.
Liburd. Sorry. Thank you, Dr. Liburd. I've heard it said that we are all in the same storm, but we're clearly not in the same boat. These underlying health disparities that have been highlighted during COVID-19, they're not new to folks in my position across the state, across the country, I should say. While it has produced great challenges, it's also produced, I think, great opportunities. And I look forward to telling you all a little bit more about our health equity response team here in the state of Pennsylvania. Thank you.
Thank you, David. I'd now like to ask Jim if he'd like to share some opening remarks.
Yes, thank you very much, Dr. Liburd. It's great to be here with David and Dr. Maybank. I think my overarching remarks at the start here, before we take advantage of this great opportunity to talk, is that public health in the United States and possibly the world is really at a historic crossroads. We have known about existing health injustice literally for decades. You mentioned the Collaborative for Health Equity Cook County. We released a report in 2012 about Metro Chicago gaps in life expectancy along racial lines, along income lines. And I think part of my message is that these inequities that are preventable, unfair, and unjust keep repeating themselves and repeating themselves. I think we must look at evidence, but the evidence is not enough. So we need to build people power. We need to build community power based on the bedrock public health value of social justice. And I think it's important to keep in mind that these movements in the streets, in the offices, in our communities are struggles for social justice, and those struggles are public health struggles.
Thank you, Jim. I'm sure there's a lot of agreement amongst our participants with what you just shared. And so I'd like to ask Dr. Maybank to share her perspectives as we begin this conversation.
Thank you, Dr. Liburd, and awesome being on this panel with Mr. Saunders and Mr. Bloyd. You know, I have been in public health for the majority of my career, the 80% of what creates health, and now I'm kind of in healthcare space of the 20% of what creates health. And I agree with all that's been already said, but what's really kind of profound for me now being in this space, and also AMA, the American Medical Association, you know, representing 210,000 physicians across the country with a mission of promoting the art of science and medicine, but also the betterment of public health. And many folks don't realize that. And I think it provides this unique opportunity to think about how does public health and healthcare come better together. I think COVID has absolutely exposed the inequities, longstanding, historical, contemporary, whether it's in health or wealth or education. But it's also elevated the need for the public health infrastructure to thrive, but definitely exposed this divide and this lack of structured and consistent connection between healthcare and public health systems at the national and local level. And so I really believe that during this time, it's time to take opportunity. And we've been here before in this country and having these conversations and trying to bring these two systems together. But I think it's really going to be challenging to advance health equity and advance equity in medicine and healthcare if we don't really think about bringing them together. If medicine doesn't really understand these larger drivers of what produces health and what produces inequities. And we're at this very unique time also in that in about a month, September 3rd, a little over a month, it's going to be the relaunch of the 10 essential public health services. And I think this is a real opportune time to revisit what this means to really embrace public health as a nation under this larger umbrella. This time around, it's really centering equity for the first time, really throughout its foundation, but also the other services as well.
Thank you, Dr. Maybank. So I think we're grounded now and ready to just start our conversation about how we can get closer to achieving health equity. I also want to thank, before we get started, everyone who submitted questions for this webinar. And we'll just go ahead and get started with our first question for David and Jim. So the first question is, how can public health departments develop and maintain empowerment and advancement of health equity efforts within different programs? David?
Like I mentioned earlier, I think this is a great opportunity for all of us. But in order for us to really seize this opportunity, we must maintain the momentum. All the work that we are about during COVID-19 really needs to have an evergreen effect, so it goes beyond COVID-19. And how do we do that? We capitalize on the new alliances that have been developed. Our health equity response team is made up of academia, nonprofit, of course, healthcare, state and local government. So while our office brought many folks to the table, we've also met individuals and connected with individuals that we had not connected with before. So we need to capitalize and maintain those alliances. We need to look at data in different ways, making sure that we have racial and ethnic data covered in a variety of different ways, and accelerate our efforts. I've been at this for about 30 years, and I've never been, I guess, more excited about the future than I am now. I've never felt that we could achieve the lofty goals that we have. So I just want, I just would encourage all of us to seize this opportunity and give it all that we have. We can, I believe, achieve health equity and eliminate health disparities if we seize this opportunity.
Yeah, thank you. Yeah, we're definitely on a new and exciting path. Jim, what do you want to add to that?
Yes, Dr. Liburd, I agree wholeheartedly with what David said about developing new alliances and working with people who local health departments and healthcare providers may not have considered as partners in the past. Because I think what is really important about this question about empowerment and advancing health equity efforts, I'd like to just read a quote that pulls together this idea of political power in science from Jason Beckfield, who's a sociologist, and of course, the social epidemiologist Nancy Krieger. They write that power, after all, is the heart of the matter. That the science of health inequities can no more shy away from this question than can physicists ignore gravity or physicians ignore pain. And so I think what that does is challenge us to, again, look at why we haven't been able to successfully enough achieve the policy changes that address these root causes, which come from social structure. They're embedded in the economic system, in the systems of white supremacy, of oppression of women, of oppression of working class people, and oppression of other marginalized groups. So an example of doing that, I think, are two things. First, we must transform and work to increase our capacity from within public health department agencies and also agencies outside of government to really tackle these public health problems and increase our understanding so we don't inadvertently reproduce the power imbalances, the racism that frankly, as a white person, I grew up with. So we must constantly fight that. And I'm proud that our co-directors, Rachel Rubin and Kiran Joshi, joined together with 22 other of my coworkers as co-facilitators to do those dialogues for Roots of Health Inequity that you mentioned in my intro. And we engaged in months-long small group processes using the wonderful units that are available for free online from NACCHO. And that has had a really important effect, not only on morale, but increasing all of my coworkers' consciousness and capabilities. But also second, I want to mention my coworker Gina Masuda's spearheading of a work with power building organizations who are tackling the plight of precarious workers. These are workers who include essential workers, so-called, people who work in low-wage jobs, people who are often from immigrants and other countries, and they are in the front lines and bear the brunt of this premature mortality and morbidity from COVID. So that's a project we've done in partnership with the University of Illinois at Chicago. And I just want to mention that those kinds of organizers build power through their members, and then we listen to their voices. And they help us. We work in partnership. We build trust. We testify with them in order to, for instance, raise minimum wages and improve working conditions. And those types of relationships then bear fruit in the future.
Can I add something
Thank you,
quickly?
Jim. Yes, please.
Thanks, I appreciate it. And Jim and I know each other for a while, and we've been working together, and I think that's part of the work of the relationships that you kind of build across the country. So very much value his leadership and word. I think just to continue with that and what's becoming real, so many health departments and institutions, including the AMA, have named racism as a public health threat now, and that we have to have action behind it. And I think part of that action is some of the work that Jim mentioned, the inside-outside strategy. We have to challenge our own staff, build their own capacity so that they understand the mental models that they bring to work every day that potentially can exacerbate inequities. But I think we also have to name, and this is one of the key criticisms really for AMA as it relates to equity work and skepticism that exists, is we have to be able to look at our own history as institutions and how we may have perpetuated harm as well, not just in the contemporary context, but in the historical context. And the majority of predominantly white institutions in this country have to own up to that. And we have to do that as AMA as well. And we need to be able to name racism and white supremacy as it contributes to the inequities and the harm with this country, because I feel if we don't do things through that lens, we're going to, again, continually be at the same point over and over again. So it's going to determine how we engage with our patients and our community partners. It's going to determine how we use our data. You know, data is very important for us as a radical tool for change. And I think if we don't really advance our narrative around the reduction of inequities in our language, we're going to end up in the same place.
Thank you. And so I want to move us along a little bit more quickly, because this is such an important and substantive discussion. But I just wanted to ask if there is anything, Dr. Maybank or Jim, that you would want to add, particularly on the heels of the discussions around power and what's been described as interlocking oppressions, the isms, if you could imagine it in that way. What role, if any, did community engagement play in the success of your COVID-19 health equity initiatives? And this is question number 2. And who were your partners, just to give our audience a sense of who else they may reach out to? And what are some examples of actions your community partners could take that would not have been possible without them? What work have you done? And just for like 1 minute, you know, what work have you done that would not have been possible without the engagement of the partners?
Jim, do you want to go first?
Okay.
Health department? I can go. Jim.
Go ahead, Dr. Maybank.
Okay. Well, I think the important thing is, it's already been highlighted, is that if folks thought of community engagement as a form of kind of emergency preparedness, maybe we would think about it ahead of time if we had formalized structures within a neighborhood. So I'm in Chicago, AMA headquarters in Chicago. And so for the first time, this last year, as I started, we actually provided funds and invested rather in the West Side of Chicago in this community-driven effort called West Side United. And so this is a collaborative effort with the Chicago Health Department, with residents, with civic leaders, community-based organizations, faith institutions, and 6 anchor healthcare institutions as well, with this whole long-term goal of reducing life expectancy by 50% in 2030 rather. And so this was already established, well-functioning for the last 3 years. So when COVID came around, it was an opportunity for the mayor's office to kind of point in that direction and say, we have this infrastructure that's in place, and let's start one of the city's racial equity rapid response teams. And so we were called upon as AMA, my researcher, Fernando De Mayo, to provide some technical assistance to the public health department. And this was specifically around actually the data piece of it, understanding that health departments, are definitely strapped in terms of resources, but there's academia, there was us that were able to kind of bring some other resources, data scientists, epidemiologists, to really look at the problem of the missing racial data within Chicago. And without going into too much detail, but what we were able to do is really reduce that missing rate from 47% to 11%. And this was all through the process of vetting this model through the racial equity response team, and just valuing the expertise of the universities, the health systems, and the community-based organizations in order to achieve this outcome.
Thank you. So I have a question that I know is also very close to the heart of Jim and Dr. Maybank, which is, how can we strengthen, and this is number 3, how can we strengthen workforce diversity now and for the future, given the changing demographics of our nation? And again, if you could give me a quick response to that, even though I know, again, like all of our questions, there's a lot that we could say.
Sure, I appreciate that. Well, very briefly, we are going to be starting our contact tracing program. In fact, I learned today that we've hired a couple of our leadership staff for the contact tracing program. But we're committed to making sure that the folks we hire as contact tracers have the skills, the knowledge, and the tools that they need to be effective. And that cannot be done unless the contact tracers actually reflect the diversity and the demographics of the people we serve, of the people who actually pay me to be here. And so I think it's also a question of political will. It's a question of being accountable to the public. But in terms of being effective, we believe that it's important to have folks who are from neighborhoods and communities or have worked in neighborhoods of communities where they will be reaching out and doing their contact tracing work. Let me point out, though, very importantly, is that I just learned today that there is significant problems with getting some of our tests on a timely basis. And this is of great concern. I've heard multiple reports about tests getting reported in 15 days. And that this may or may not be general around our area, but if we don't take care of this problem, our contact tracing will be rendered very weak, if not impossible.
Thanks, Jim. And Dr. Maybank, I know that you have a lot of thoughts about how we need more diversity in our healthcare workforce. Please share with us.
Sure, especially our physician workforce, which is what we're focused on. I mean, the reality is still only Blacks make up about 5% of the physician workforce, Latinx about 5.8%, Native Americans and Indigenous only 0.3%, and Native Hawaiian 0.1%. So we're still largely excluded from an opportunity of becoming a physician. And so during COVID, what we took the opportunity to do, oftentimes folks aren't talking to physicians that are racially marginalized. So we launched a survey over the past few months to understand the experiences of physicians that are racially marginalized, and really found that 91% of these doctors are having patients that speak different languages other than English. And for the most part, Black and Latinx physicians are significantly more likely to proportionately serve patients of their own race and ethnicity. So that's really important because evidence shows us, and some of this work is from Owen Garrick, that race concordance actually builds trust, better communication, adherence, as well as potentially outcomes. So the insights of our study really help support this need to have an increasingly diverse workforce in medicine. And so we were trying to do a lot to figure out our role. There have been people who've been doing work around increasing workforce diversity and preventing exclusion for years. And so for us, you know, as AMA, it's like, what is our best role in that space of figuring that out? And what we're really learning, you know, there's a lot of work around pipeline programs for sure, but in having lots of conversations with people, a lot of this is what Jim mentioned, this will, you know, this will to do it, making commitments to equity, holding people accountable, especially at the admission committee level. Because there are schools that do diversity really well. At the end of the day, you know, you look at Morehouse School of Medicine, they do diversity, they know how to do it. And so it means it can be done. And so it's about holding folks accountable as well and having leadership to do so.
Thank you. And so I'd like David to bring you into this question, and then Dr. Maybank, but what policies, and this is question number 4, should be put in place to ensure health equity is integral to how we respond during public health emergencies in general? When we move past COVID-19, what are the policies that we need to be sure are in place?
Well, let's start off overarching, and that offices of health equity should be a part of the overall emergency response. Equity considerations should, in fact, be part of our overall emergency plans, and ideally before an emergency hits. So that's in general terms. Some of the recommendations that have come out of our health equity response team, and for the audience, just to mention several of the vulnerable populations that we're looking at. We're looking at folks over the age of 65. We're looking at racial and ethnic minorities, LGBTQ, pregnant women and parents of extremely young or multiple children, rural Pennsylvanians, just to name a few. Some of the policies, somewhat of practice as well. Replace the advanced and costly technology that will enable us to do more around telehealth and telemedicine. Enact employment and workforce development for incarcerated and returning people. That was one of the groups that we're looking at, incarcerated and returning citizens. Collect information regarding preferred language during COVID-19. Releasing of LGBTQ inclusive sexual health guidelines, epidemiological systems of data collection on COVID-19 pandemic and racial and ethnic communities in the state, addressing social isolation. Just to name a few, Dr. Liburd, you mentioned we had 60 recommendations. In fact, that number has jumped. We have 69 recommendations. And I think many of these recommendations, again, will have that evergreen effect and can impact health equity going forward beyond COVID-19.
Thanks. And Dr. Maybank, what policies are you championing from the AMA?
Yeah, there are most of what David just said, I'm in agreement with. I think there's a value that needs to happen that, you know, all policy is health policy. And again, it's that change in narrative around health. It goes back to my earlier statements of how do we kind of prevent this divide of like what we're doing within the context of the healthcare system and what's downstream. And clearly it's important that, you know, we're putting forward and advocating for policies as it relates to protection of frontline workers and anything as it relates to COVID most immediately and downstream. But we have to also look more upstream and think about health and equity in all policies kind of approach. We have to value that health is a human right as well as a public good, and that this lens of anti-racism and structural justice in order to get there needs to be put on the lens, as we put these policies forward and as they are developed. And I think in order for that to happen, there has to be that commitment again to dismantle racist and discriminatory practices within healthcare. And I think there has to be big P policy that helps support doing that, but also our own institutional policy that requires training, not just bias training or implicit bias training. I think that's used much, actually too much, but get more into the roots of anti-racism training, but even broader than that, identifying resources and people who can really focus on institutional and culture change, so that when policies are developed and created, you know, they're through this lens, but they need that policy piece in order to have the accountability, because hearts and minds, we want to be there, but they're not necessarily always there right away and immediately. And so we need the policies to help support us moving in that direction for sustainability.
Thank you. And David, I'd like to bring you back into question 5, which is how to inform health equity efforts and its impact on the affected communities, on community leadership and other local stakeholders for awareness and advocacy.
Well, first, a little secret I'm gonna put out there to all of you. The public health department does not have to have all the answers. The actuality is we don't have all the answers. So as part of our health equity response team, you know, as I mentioned, all the different individuals coming from a variety of different disciplines. So bringing those stakeholders to the table. Our tent continues to be open. We've been at this since April 22nd. We're still, you know, enabling others to join us in this effort as we move from recommendations to implementation. So engaging stakeholders, giving them ownership. So out of our leadership, some of which are participating in this webinar as we speak, they basically run the show. They set up the agenda for their committee meetings. They coordinate the process of developing the recommendations. They will develop now an action plan to implement those recommendations. They determined who the speakers were that would come in and inform their discussion. So giving them ownership, empowering leaders outside of public health, the realization that we don't have all the answers, engaging various partners. I think Dr. Liburd are all keys to continuing this effort going forward and really providing those perspectives that can only come from the Department of Health.
Absolutely. Thank you. I want to bring up question number 6. I want to start with Jim to get his perspective on this, but I think that this whole focus is one that's of concern to all of us in public health. So how can we enhance data sharing strategies, particularly social determinants of health data across different programs within public health departments? Jim, do you want to get us started? Jim, you're on mute.
Thank you. I was saying that I think it's important for folks inside of public health departments who are developing data to make a clear distinction between structural determinants, the social determinants of inequities, rather than just the intermediary resources, the social determinants of health. Those are two important distinctions because when we talk about social determinants of health, it could become something like actually just focusing on individual behavior change, which we know has not worked to prevent health inequities and could in fact even worsen them. So we need to look at, for instance, income. And to go back and give an example where you talked about interlocking kinds of oppression, I want to look at kind of immigrant folks and low-wage workers. We know that ICE creates fear in communities, and it creates fear particularly for folks who are more vulnerable, who are not able to work from home. So they may feel unable to take advantage of public health or healthcare services or other kinds of social services. In addition, we know that the healthcare economic sector has a wonderful opportunity to tackle health inequities structurally, because 1.7 million women of color and their children result in living in poverty because of the racist and sexist wage structure of the healthcare sector, particularly hospitals. So I think it's a really important opportunity for folks in the healthcare sector to take advantage of. And so I think sharing this data within health departments is important, but also we must share this data effectively with the people who are in the streets, the people who are bearing the brunt of the inequities and have been for decades, in addition to now. We need to work with them to listen to their priorities and to develop data that helps them in their struggles, again, for social justice. And I want to point out that my coworker, Freda Holloway-Beth, did some unique research here in Illinois that showed that police killings and police injuries were disproportionately hitting Black folks at not only the urban level, but also suburban and rural areas across the state of Illinois. So I think these are the kinds of data that need to be provided to folks who are struggling for social justice.
Thanks, Jim. And I want to, and like we have just a couple minutes before we want to open it up to our audience for questions, but I'd like to get Dr. Maybank's perspective as a physician. Like, how can physicians use social determinants of health data in their practices or in their delivery of care? How is it significant for them?
Yes, I mean, it's very significant. And I think many physicians want to be able to collect that data. The challenge is having the infrastructure to be able to do so is not quite fully there. There are examples across the country. There was a piece published in Health Affairs, New York hospital system, the public health hospital system here, H&H, has done a great job at collecting social needs. Sorry about that, my computer's about to die. Has done a great job about collecting social needs. But I think what's also important is what Jim mentioned, is that there has to be clarity on kind of the language that we're using. Most of the work that we're doing at the healthcare level is about understanding social needs. It's not really about the larger context of the social determinants of health within a neighborhood or the inequities around it, or even the structural determinants as well. And so we still have to build up what that kind of methodology and analysis would fully look like for the healthcare system. Where the opportunity is that there is an existing network called the Healthcare Anchor Mission Network that's coordinated by the Democracy Collaborative. And this is about 2 years old, and it's a network of major healthcare systems across the country that have now made commitments to move upstream. In other words, think about how are they supporting not only their patients within the hospital walls and collecting information on social needs and building those systems to do so, but also what are they doing in the context of the neighborhood? What investments are they providing more upstream for job development, business development, housing, affordable housing, and all of that? And so I think that there's beginning to build a readiness on the healthcare side and an openness to be engaged with public health departments. And this is, I think it provides a wonderful opportunity to do so. The Westside United effort that I mentioned earlier, Rush University Hospital is a part of that, and they are part of the Anchor Mission Network. And so they have this a kind of culture, I guess you could use the word, in which they have this tendency to reach out and engage with the local health department and with the community residents. So I think that there are now models that are building that have this kind of cross-collaborative, which I think is going to be very important when it comes to data sharing opportunities as we move forward, and being able to set standards as it relates to collection of social needs, as well as the determinants more broadly.
Okay, so I'd like to turn the microphone over to Lamont Scales, who is going to ask the questions. Some that we've received from our audience, some that we received in advance, and then I will call on one of our panelists to respond. Lamont?
So thank you, Liburd. I'm Dr. Liburd. We have over 100 questions and almost 3,000 participants on the webinar. So we won't be able to get to all the questions, but we'll get to as many as possible. The first question that we do have is, how do we define health equity?
Okay, so I'd like to ask Jim if he'd respond to that question.
Sure, thank you very much. I mean, there's multiple definitions. I think the one by Dr. Kamara Jones is really good and wonderful. And she talks about three things: really valuing all lives and all people equally, and then looking at and dealing with, being aware of and dealing the historical injustices, the historical development that has put us in the predicament that we're in, including white supremacy, including slavery, the foundation of slavery 400 years ago, including the dispossession and theft of indigenous folks' lands, which is, I'm here on land that was stolen from originally inhabitants from the Ho-Chunk, Potawatomi nations and others. And then also providing resources according to need. And that last one is crucial. And I think even now, while we're addressing this obviously racist, sexist, classist outcomes of COVID-19, that we still struggle with that. And again, that's why I come up with the crucial need to build community power.
And tied to that, just to add real quickly, is I think it speaks to, you know, and Jim talked about one piece of it, the data piece comes back up and comes to mind, so that if we're trying to redistribute it based on need, our data has to be present. The reality is still we have lots of missing race and ethnicity data, up to 40% in some communities across the country, even higher. And we have to ensure that when data is analyzed, again, that we're considering the systems and the structures of oppression that Jim just highlighted in the consideration of how we set up and how we determine risk, because we have this challenge of either overestimating risk or underestimating risk, therefore potentially creating further harm, because we are not going to give the amount of resources that are needed for certain communities. And so how the ability to collect data and systems that are set up to do so, but then how we analyze the data and the methods that we use are absolutely critical and important for us to fully advance equity.
What's our next question?
Yes, the next question is, can you share strategies on how to ensure that highlighting racial inequities in COVID-19 can be done in a way that minimizes unintended harm, i.e. stigmatizing racial and ethnic communities, and incorporates community perspectives on data use, i.e. nothing about us without us?
Thank you. David, would you like to respond to that?
Give it a shot. I think the highlighting of, you know, the essential workers, or more so the frontline workers, and how certain individuals are more susceptible. So all of us are able to sit in our homes for the most part and telework. Those that cannot are more susceptible because they are exposed. I think highlighting the real reasons or the causes for the additional susceptibility that certain populations have, I think are the key. I think hearing from the community in regards to their concerns around COVID-19 and issues like COVID-19, I think would help quell some of those issues around not hearing from their perspective.
And Data for Black Lives just put out a report in April that folks would want to check out. It's all about contemplating how data is used for a tool of social change instead of a weapon of political oppression, and really focuses on how data must be interpreted in the proper historical context, considering the various elements of structural racism like redlining, racial residential segregation, gentrification, healthcare segregation, and is really informed by our public health ecosystem.
Thank you. Lamont, our next question.
Yes. How are you or your staff using health literacy concepts to better communicate with the public, in particular with racial and ethnic minorities?
Jim, would you like to start us out? It's an important question.
Sure, I would. Thank you. You know, I think it comes down to really listening carefully, doing as much careful listening, and with a change of maybe mindset of working with people who are oppressed, folks who are in neighborhoods with higher rates of poverty, concentrated poverty, for instance. My coworkers, April Talbert, Kelly Jones, and Bridget Carter, have been doing a program called Co-Design Groups. So they have success in working with grassroots folks who are trusted by community members. And I think where they encounter differences in communication or myths, that because of the long-term commitment they've made, they're able to overcome some of these issues of literacy or of miscommunication, and actually have been able to correct kinds of messages that otherwise the Cook County Health Department may have invested a lot of scarce resources in using, say about contact tracing. There's a lot of myths out there about it. There's a lot of myths about masks. And so I think part of it starts with this idea that I think David brought up also about trusting the people you're working with and starting where they're at and working closely together on common issues.
Thanks. So I'm going to ask Lamont if he would want to bring our next question. We won't get through 100.
Sure. Under our current circumstances, are you finding new and different types of collaborations? If so, can you elaborate on these types of collaborations?
I think David spoke to that in the work that's going on in Pennsylvania. David.
Yeah, I have a good one. Faith-based testing. Something that we're developing as we speak, a couple of pilots here in Harrisburg, Pennsylvania, and in Pittsburgh, working with churches, connecting them with FQHCs and other healthcare providers to not only provide asymptomatic and of course symptomatic testing, but also in the same breath, if you will, provide education and awareness to get at some of those risk mitigation, communication areas, and also to provide PPE. That would be the dream, is just like churches provide food through their food pantries, they would also provide PPE as well. So we're working on that process as we speak. We hope to have a couple of pilots going later on, or actually next month. So we'll have more to communicate out shortly.
And as the AMA, oh, sorry about that. And as the AMA, one of our unique partnerships that kind of has flourished, and it was launched this past April, was with Essence Magazine, which for those who don't know, or Essence brand, is kind of the leading brand for women, Black women in this country. And in recognizing that, one, you know, so we have our epidemic of COVID, but then folks, we know from the data, we're still not going, and we're not going to seek care because of fear of either going to the hospital or to their healthcare institution. And so some of their chronic diseases were being left unmanaged. And so this is a particular partnership that's focused on, it's called Release the Pressure, and it's focused on engaging women of color as well as their families, Black women more specifically and Black families more specifically, around hypertension management and control during a COVID period time. So what they can do with their home, but also what can they do with their squads and with their families in order to ensure that they still have management. And so that's a really, just for the American Medical Association to step into that kind of partnership. It's been a wonderful opportunity. And the other opportunity actually is that we've been doing it in partnership with the National Medical Association, which is the physicians, the Black physicians that were actually excluded, and they started their own organization years ago, but also the Association of Black Cardiologists with the American Heart Association, and the Minority Health Institute and the American Medical Association Foundation. So we have this huge collaborative effort to really focus on chronic disease prevention and care during this time of COVID.
Thanks, Dr. Maybank. So Lamont, I think we could possibly have one more question before we close out.
Yes, can some of this work be translated into the global public health sector?
Hey, Jim, would you like to speak to that? Jim, you're on mute.
That's the second time. Thank you. The Cook County Department of Public Health has adopted the World Health Organization's social determinants of health approach. And I think people around the world internationally can use that. It's grounded in science. People's context, though, is different. Everybody has a slightly different context, and that's crucial for the kinds of pushback we get, the kind of support, the kind of funding. But I want to mention a nice concept from Fran Baum of Australia, and she talks about the power and health inequities, and she talks about the tough nut of health inequities to crack. And if you think about a nutcracker using leverage, Dr. Baum, again from Australia, talks about the need for elected folks and policymakers to be working in partnership at one lever of that nutcracker, and that there's community action for health justice, collective action from people power, if you will, at the other level, and they crack open that nut of health inequities to have the kind of structural policy we need. So I think these types of strategies can be applied and discussed. The idea of nothing about us without us is for us. I think these kinds of concepts are indeed maybe universal and could be useful to people around the world.
Thanks, Jim. Well, I can hardly believe we've spent a whole hour already. And I just want to, first of all, thank our awesome, amazing, brilliant panelists for sharing their expertise with us today, sharing their experiences. I can tell just in kind of glancing at the chat box that people who are participating with us today are really engaged, that many of your comments have been resonating with them. And I want to thank all of our participants. I know at one point we had over 3,000 people who joined us today. So we thank you for your time. We thank you for the work that you do every single day in the community to address not only COVID disparities, but health disparities, inequities, and health equity in all forms. And so thank you again. We look forward to continuing these series of webinars on promising practices in health equity, and we look forward to seeing you at our next one. Stay well, and thank you so much for taking the time to spend with us today.
Thank you, Dr. Liburd.
Thank you all.
Thank you, Dr. Maybank. Thank you, David.
Thank you. You guys take care.
Everybody.
Big hugs to all the public health folks.
Thank you.